Now it's back. Okay. If it fades out, just let me know. Okay. So we'll spend the next 45 minutes talking a lot about methamphetamine use disorder. And my goal is, I think like Lauren, I really have had a lot of feelings of like, oh my gosh, there's just nothing we can do about this thing that is really, really hard for patients. But I'm hoping that we'll be able to move kind of a little bit more towards a space of feeling some agency and just having a little bit more kind of context about what we can do both as healthcare providers and more broadly as advocates for our patients. Okay, so no disclosures. Objectives, kind of similar to Cody's talk, this will be about creating a framework so that we have kind of a shared mental scaffolding for how to approach meth use. And think about it in sort of 3 different domains. But before going into kind of what that framework is, I do really want to center this kind of like around the just experience of taking care of patients and how hard that can be as providers. So I'm actually going to ask that you take about 30 seconds and think about a specific patient that you've taken care of, either inpatient, in clinic, maybe in the emergency room, who was experiencing meth use and how that was somehow affecting their health. So if you just take maybe 30 seconds, think about that particular patient, maybe like imagine like what they look like, what their face was like if you remember it, their name if you remember it. Okay, and so holding that, again, it'll be kind of 3 different areas that we'll talk about. And the first is sort of when you're going and meeting a patient and you're sort of at the bedside with them, what are the things that you can do to reduce harm kind of in that interaction, engaging with them as a healthcare provider? And specifically, we'll talk about recognizing and managing complications associated with meth use, and then implementing a harm reduction checklist for any patient who has a substance use disorder. And next is thinking about your role connecting your patient to broader sort of Seattle resources, and then sort of connecting them to other people on your team who are really sort of specialized and have expertise in that, and spend just a little bit of time sort of talking about some of the Seattle organizations that are out there and doing cool stuff. And then finally, thinking about being an advocate. And so I think that treatment is actually like a huge area for advocacy because the sort of bottom line is that there are no FDA approved medications and really no guidelines of any kind to sort of guide how we help patients manage the condition. But I think that sort of moving towards a place of more funding and more energy around that kind of research is a big space for physician advocacy. So we'll talk about kind of what the current evidence is and possible directions that it might go in. And then finally end by talking about opportunities for community advocacy, because there's a lot of really cool stuff going on in Seattle. And then finally, so a lot of the material from this comes from a conversation that I had with Jessica Warmbo, who's one of the social workers on the addiction medicine consult team at Harborview. She's awesome and has been doing this work for a lot of years. And I wish that she were able to be here to just kind of give this talk, because I think that would probably be the highest yield way of getting this kind of information across. But in lieu of that, kind of sprinkled throughout, I'm going to have these like little orange expert pearls, which are basically trying to distill down sort of like the major points from her conversation and the things that she would really want us to be able to take away from her perspective. Okay, so to start, this is something that will probably not be surprising to anybody, but there's a lot of meth in Seattle. And there are different ways of kind of measuring and quantifying that, but I thought that this was a particularly striking example. So this was a paper from recently, it was published in December 2020, basically looking at for all patients who come into the emergency room who have untreated opioid use disorder. So they have a positive UTOX with opioids, but are not on any kind of medication-assisted therapy, so not on methadone or Suboxone. How many of those people also have methamphetamine in their urine? This was by no means a national study. They were just looking at 4 different sites across the US, but a huge difference. So Baltimore, New York, kind of East Coast cities tended to have more just opioids, but Seattle, there's obviously a huge overlap, and there's just a lot of meth kind of around. And so the first expert pearl is that meth is ubiquitous in Seattle. Jessica mentioned that she often found that patients would encounter meth even if they aren't seeking it out because it's just sort of in the environment. And a corollary of that is that if someone is looking to remove meth from their environment, which can be a really sort of important part of recovery, it can be logistically very difficult to do. That sort of finding housing or finding any sort of environment for living that doesn't necessarily have meth in sort of around it can be really challenging. And then similarly, sort of as more meth has come into Seattle, the rates of overdose have increased as well, but pretty dramatically. So between 2008 and 2016, the overdose rate actually quadrupled. And so these are deaths that were really primarily attributed to methamphetamine overdose with no other sort of other primary cause that was seen. So big change there. And then I think, again, not a surprise that this tracks along sort of other forms of social inequality. And so this is national data. And if you look at the age-adjusted rate for cocaine and psychostimulants, the communities that are really disproportionately affected are Black and then American Indian, Alaska Native. And this bears out in Washington State as well. This was from a 2018 report from UW, sort of commenting that the Native American community is about 2% of the population in Washington State, but are overrepresented in the number of overdose deaths attributed to methamphetamine. Okay, so I'm going to move into the first part of the framework, which is thinking about sort of what can you do while you're at the bedside with the patient. And I think this sort of fits broadly into the idea of harm reduction. Would anyone be able to just kind of quickly shout out or type just kind of how you conceptualize harm reduction, like when you hear that, like what it means to you? I also have to figure out how to see the chat, which I don't know how to do.
Yes, I can shout out what it sort of has meant to me. I don't know that I have a very formalized definition, but I guess it has meant sort of like within, oh, Jocelyn has answered too. And I guess I kind of agree with Jocelyn, but like talking to the patient and figuring out like what they are willing to do and where they are at with sort of what they want to do with their substance use disorder, and offering whatever you can to help make their substance use safer for them. And offering whatever amount of treatment for their substance use disorder they want to accept, and then sort of reducing harm as much as you can to them for whatever amount of substance use they're going to be doing. That makes sense.
Yeah, totally. No, that's awesome. That's like right on, and yeah, hits the nail right on the head. So yeah, it's a sort of framework that very specifically thinking about substance use sort of really privileges patient autonomy and what the patient wants and kind of what their goals are, and our job is to sort of be a resource for them. And then it's kind of this bigger picture sort of social justice movement around really trying to change the way that sort of as providers we interact with patients who are dealing with really stigmatized illnesses. So one of my favorite definitions tried to sort of pull out the underlying principles of this kind of care, and specifically came out with humanism, pragmatism, individualism, autonomy, incrementalism, and accountability without termination, which can maybe be more succinctly summarized as keeping people alive and treating them with dignity, which is how Jessica really kind of described it and understood it in her own kind of work as well. Okay, so we'll go through a quick case. It's 9 p.m. on cardiology. This is a page that you will probably see if you have not already done cards. And so you're meeting Sam. They're a 42-year-old patient. They have a history of HFrEF. Their EF is pretty low, 15 to 20%, and they have ongoing methamphetamine use. They're coming into the ED with leg swelling, shortness of breath. You're concerned about acute decompensated heart failure. This is an admission that they've had a lot of times before, and so this is kind of a pretty typical constellation of symptoms for them when they come in. And then I'm just going to quickly say I can't figure out how to see the chat. I thought I had, but if anything comes up, feel free.
I'll let you know too.
Okay, sounds good. Cool. Okay, so on your way down to the emergency room, you're thinking about whether Sam could be at risk for acute meth toxicity. So what kind of things come to mind? Like when you think about sort of in the acute setting, someone's just done meth within the last few hours, what kinds of things might you be worried about?
I think in the case of his heart failure, like if he, was really tachycardic, that could exacerbate his heart failure. Or becomes hypertensive and like greatly increases his afterload and can further exacerbate his heart failure as well.
Mm-hmm. Yeah, absolutely.
Similar comments in the chat. High blood pressure, MI risk, tachycardia, stroke risk, vasospasm are some of the things people are typing in.
Yeah, awesome. So all the cardiac stuff for sure. So you can have an acute cardiomyopathy, or if someone has a more chronic cardiomyopathy, then that can acutely become much worse. You're also at risk for vasospasm, like someone said, aortic dissection. And then you can have both pulmonary edema as a result of the cardiomyopathy and non-cardiogenic pulmonary edema, which is mediated through a little bit of a different pathway. And then some things that I actually wasn't very familiar with can cause acute mesenteric ischemia through similar pathways of vasospasm, as well as AIN and tubular necrosis. So you can see acute renal failure, and then as people said, stroke, as well as seizures and psychosis. And care for any of these is really supportive. There isn't sort of any particular antidote, obviously, to meth, but these are things that kind of in the immediate setting can cause potentially death. Or really serious illness. So those are the kind of like going down to the emergency room, things you want to have on your mind as you're evaluating someone. And so say you get there and they look pretty stable. They're kind of up and talking to you, not having any seizures, not having any active chest pain. And so then you're thinking more about what are the long-term complications of methamphetamine exposure and what are you looking at? A lot of these we've already hit on, things like cardiomyopathy. Other things that come to mind, things that happen kind of over the long term with meth.
So in the chat, tooth decay, chronic skin irritation and infections, pulmonary hypertension.
Yeah, awesome. So cardiomyopathy, pulmonary hypertension. I actually forgot to put a box for dental damage and things like that, but that's absolutely part of it. And then the other big category are the neurocognitive effects. So I think it's summarized pretty well by this picture. The way meth works is sort of on the dopamine serotonin transporter systems. And unfortunately, there's a really big lag time that sort of takes after someone stops using meth for those systems to recover. And so this fMRI picture, I feel like just sort of really viscerally captures that, which are sort of looking up the areas of the brain sort of involved in serotonin dopamine transmission in a healthy person, in a meth user 1 month after abstinence, and then 14 months later. So you can see that sort of within these pictures, it takes 14 months before you see that sort of full function return. In reality, it's often, I think, a little bit shorter, maybe more like 8 to 12 months. But when you think about sort of opioid withdrawal or something, or alcohol withdrawal is a syndrome that might last several days, this is a syndrome that might last months, which is sort of a different picture. And so Jessica mentioned that it means that decreasing meth use is hard for a lot of different reasons, and that she felt like this was a really important point to sort of include in your counseling for patients, and just in sort of like formulating sort of what does it look like to stop or decrease meth use. So it can take away a key coping mechanism, the way any substance use can be sort of playing a role in just sort of getting through every day. But then second, in Jessica's words, patients feel like crap for a long time. So it just might take someone months before they really start to feel back to normal. And that means feeling depressed and having cravings and having some cognitive slowing. And that's something that really doesn't get better quickly. Okay. And so another big area for sort of thinking about how do we reduce harm for people who are using is around thinking about sort of like the causes of overdose and death. And so a large number of that for meth is going to be related to all of the acute toxicities that we just talked about, as well as the more chronic ones. So from heart failure, from seizures, if someone goes into status, things like that. But if you look at, so this graph is looking at sort of all deaths in Washington state that were primarily attributed to methamphetamine. And the purple is deaths that had just methamphetamine involved. The orange is deaths that had both opioids and methamphetamine. And the takeaway here is that a lot of deaths do involve both, and you don't necessarily know sort of which the driver of the sort of fatal overdose was. And what that means is that it's really important to give people naloxone. Even if people aren't intending to use opioids, there's a fair amount of fentanyl in Seattle that can be used to cut meth. And so even if people don't think that they're necessarily at risk, because methamphetamine can be cut with fentanyl, then oftentimes people will, and especially if they're relatively opioid naive, that can be really dangerous. Jessica also emphasized providing information about the rising rates of fentanyl and methamphetamine. We'll talk a little bit later about test kits. There are some resources where patients can actually test their supply for fentanyl, which is a pretty cool sort of way that people can sort of get a little bit more information on their own about what they're using. But one thing that we can do sort of on the inpatient side or in clinic is to make sure that everyone gets naloxone before they leave the hospital, and really encouraging them to have it with them, even if they don't intend to use opioids specifically. Okay, and then finally, I want to go through sort of a checklist that you could use in your notes just to help sort of try to make a little bit more regimented sort of the things that we can offer to really anyone who is coming in with I think substance use disorder, sort of thinking specifically about illicit substances for the most part. I think that would be kind of really where this applies. So can people just throw out sort of things that come to mind for things that you do try to standardize in your practice?
Offering testing for HIV and Hep C and Hep A, and sometimes for Hep B, depending on what method they're using for their substance.
Yeah, awesome. No, that's huge, definitely. Okay. So this is probably longer than it would ever make sense to include in a note. So you could kind of like pick and choose things that maybe seemed relevant or sort of the most useful. But so you're admitting Sam to cardiology, they seem warm and dry, so you start some afterload reduction and diuresis. You feel okay going into the night, so you're like doing your checklist to kind of tidy up your note before you go to bed. And so I think I would include on the list, do they have concomitant opioid use disorder? Because I think that that's not always, we sort of will think about polysubstance use and sort of label it that, but really thinking like, do they have a separate opioid use disorder? In which case, you should offer them that. Meaning methadone or Suboxone, and just making sure that that doesn't kind of get lost in the shuffle, especially if you have a patient who's coming in with a predominantly methamphetamine related comorbidity. And then I would also, so when I was in cardiology, I found that it was often sort of a difficult clinical question to think about sort of what was limiting us from increasing someone's guideline directed medical therapy. And I think oftentimes we don't for really good reasons. Like if we're not sure that someone's going to be able to come and get labs and you're worried about hyperkalemia, or if their blood pressures are soft and there's not going to be a good way to sort of follow up on that. I think that those are all really good reasons that we are cautious. But at the same time, I think that people's sort of situation changes over time. And so just making sure that sort of every time you encounter a patient, even if they've been here time and time again, just thinking about like, has anything changed? Like, is there something that would make me now feel more comfortable, sort of up titrating things or adding something on that wasn't added on before, to make sure that we're doing the best that we can to get patients sort of like the gold standard treatment, specifically for heart failure. And then making sure that you do go ahead and just think about their routes of use, because that sort of changes your harm reduction counseling. And then based on that, offer counseling. We'll go through a little bit sort of more specifics about what that might look like and what counseling you might offer. But I think, again, just having it as a reminder to like be sort of a really quick part of every sort of interaction that you have with someone can be a helpful reminder. And then HIV and Hep C are the big viral testing to do. And it is also helpful to know Hep A and B vaccine status if you can. It's really hard to get Hep B vaccines inpatient, unfortunately. It's like a whole ID consult thing. So unfortunately, you're probably not going to start that series for them if they need it. But there have been big outbreaks of Hep A in Seattle relatively recently, and especially affecting the homeless community. So checking whether they have Hep A IgG and then vaccinating them if they don't is definitely a really awesome thing to do. And then making sure that there's an expert consult in for everybody. They actually, this is kind of cool, they basically like scan the UTOXs of people in the ED and will auto consult on anyone who has a positive UTOX. But it's also helpful to kind of like reach out to them directly. And then again, making sure that you have naloxone at discharge for everybody. Any questions, thoughts, additions?
Going on the topic of the GDMT, I know there's we're taught about this like beta blockade and concern for unopposed alpha. What's your thoughts on that in terms of methamphetamine?
Yeah, that's a good question. I will say I don't know the pharmacology well enough to totally comment. I think about it more with cocaine, but again, I think it's like a somewhat theoretical idea. Yeah, it's a good question. So methamphetamine is a I can't say it, sympathetomimetic, kind of similar to cocaine, but I don't know if it has the same alpha activity. So that's a really good question. I will look into it and let you know. I haven't encountered that on cardiology per se.
Yeah, I've just heard some people mention it, like, sort of thinking about like the similar mechanism of action to cocaine, but I hadn't actually ever heard if there was like any evidence for it, or like, or should we, if that's something we should actually be worried about?
Yeah, no, it's a good question. And I think like off the cuff, I would say that I think probably the risks of that are quite low, and we tend to do more harm by sort of leaving things at pretty minimal dosing, but definitely something worth looking into. Okay, and so just to kind of summarize like what the checklist tries to accomplish, I think the checklist really captures like what we can do for patients. And when Jessica was talking, so she, I think, really made the point that in our encounter with someone in the hospital or in clinic, decreasing or stopping methamphetamine use is an incredibly difficult, complicated thing that often requires a lot of different resources. But as medical providers, the things that we can do are give Narcan, test for HIV and Hep C, and really try to help keep patients alive so that if they do want to decrease or stop use in the future, they have that opportunity. Or even if they don't, that they sort of are treated with the same kind of dignity and quality of care that we would offer anybody. And so that really kind of boils down to those essential things. Okay, so I'm going to shift gears a little bit now to think about what are the different resources that are available in Seattle that you can connect people to. We won't go into this into a huge amount of detail because the bulk of this work obviously is sort of take the expertise of nurse care managers and social workers and things like that. And those are integral team members of the addiction consult team, as well as just kind of the inpatient teams generally in setting up methadone care for people with opioid use disorder and things like that. But there are some specific things I think are helpful to think about with meth. And so kind of similar to Cody, I think it's helpful to think about the sort of basic needs that people have and what are the most important things that we need to address. And so obviously Maslow's hierarchy of needs is a helpful way to think about that. And I think it's helpful to reflect a little bit on where meth might fit into these things. And oftentimes it can play a really functional role in meeting both safety and physiological needs. So I'm going to offer a little bit of language here for sort of how to ask or talk to patients about their meth use, but not really focusing on any kind of change talk. So this isn't like questions to ask to see like, are they interested in stopping or interested in decreasing? But more questions just for like us to figure out sort of what role does meth play for them? Like, what does it help with? What does it offer? As a way of sort of then understanding like what kinds of resources might be most useful to you. And so I think it's always helpful to just ask permission, but you can be like super upfront about it. So just to ask, like, is it okay if we talk about meth? And as your doctor, it helps me understand what's happening in your body. And usually I think it's okay not to kind of beat around the bush. And then sort of normalizing that sometimes people find that meth can be really helpful. And so asking, does that resonate with you, and what kinds of things do you find it helps with? I think one of the examples that people encounter the most is taking it to like stay up all night to for security and safety reasons. So either to keep watch over their stuff or to keep from being attacked or things like that. So that's a really common role. But I have encountered some other ones that I like never would have anticipated. Like a patient who had pretty severe COPD, who really like understood the meth as like having helped her in crisis moments where her breathing was really impaired. And so for her, like she associated the meth with helping rather than the inhalers. And I think that's like worth a discussion and kind of like providing information about, but at the same time, it's also really helpful to understand that like she saw the meth as like a potentially life-saving intervention for her. And just sort of, understanding the role that it played for her and what her thoughts on decreasing might be. It was really helpful to kind of have that information. And then finally asking, I'm curious if there are things that you do to make using safer. So we'll again talk a little bit more about specific harm reduction strategies, but a lot of times people are already doing things. So already getting clean needles, already making sure that they're only using their own supplies, or doing things like using lemon juice or licking needles or things like that, that like maybe are intended to be like safety measures, but probably aren't achieving that effect. And that's like an area to give people more information. And so big picture, the goal of having these conversations sort of in the clinic or in the inpatient setting is to build trust with people and give them facts. Jessica, again, really emphasize that like this encounter is probably not going to be an encounter that's going to sort of help someone completely stop meth use and move on with their lives. But most people have been, or a lot of people have been sort of mistreated by the medical system. And so trying to help people feel comfortable talking about their substance use in this moment in kind of an open, safe, non-judgmental way, so that it feels safe to talk about again in the future. And then just for kind of reference, this is the list of resources that SBIRT has that they actually give to patients. So it's pretty comprehensive, going through both outpatient treatment programs, inpatient treatment, where to get things like methadone and Suboxone, and then other more sort of like community resources. Caveat that a lot of this is not working the way it used to in the COVID era, and it sounds like that's also a really moving target. So different things are kind of open at different times, and the intake and just kind of knowing how that all works can be pretty confusing. But there's one in particular that I want to highlight, called the People's Harm Reduction Alliance. So this is a really cool organization that's been working in Seattle for a couple of decades. And it's run by, and sort of the organization is governed by people who do use or did use drugs. And so it's sort of a really peer-oriented organization. And one of the big things that they offer, so in addition to being offering methadone and Suboxone and a syringe and needle exchange kind of in different sites throughout Seattle, they're one of the only organizations in Seattle to offer clean snorting and sniffing kits. And so for people who do use crack and methamphetamine, or cocaine and methamphetamine, oftentimes like that can be a portal entry for hepatitis C or sort of or other things like that. But it's also, in general, we think of it as a slightly less harmful way of using than injecting. Your risk of endocarditis and things like that are lower with intranasal use. And so if people don't know about that, it can be a helpful thing to just to sort of make people aware of. Jessica felt like because it's so much easier to get needles and syringes, oftentimes people who might not otherwise care to use IV end up using IV just because it's easier to get supplies and try to be safe. But making sure that people are aware that, that this organization is out there and also has ways to promote safety for other forms of use. Okay, any questions about all of that?
Mary, this is Shri. So it sounds like in the vein of harm reduction, you do preferentially counsel patients on specific routes. I'd like to hear a little bit more about that. I've never done that before, and I think my knowledge base is probably inadequate to do it well.
Yeah, definitely. For sure. So I think there's definitely like specific guidelines around sort of specific ways of use. I should have included a resource. There's a really good one sort of on methamphetamine specifically, because I agree with you. I don't know all the ways of use either. There's sort of big picture like IV versus intranasal, but then it's also possible to take it rectally and then do skin popping and things like that. And so there are a lot of resources out there to sort of like very specifically go through kind of what the different modalities are and think a little bit about the sort of hierarchy of risk. And I'll look for those and put them out to people. I think it's okay to not necessarily go too much beyond the IV versus intranasal on a first meeting. I think again, sort of like understanding the limits of our own knowledge base. I think if you do feel comfortable, if someone does feel comfortable kind of with that broader knowledge about all the different forms of use and feel comfortable asking those questions, I think that is like a really great asset. But at the same time, I think it's sort of low-hanging fruit to provide information about sort of other ways that people can get safety equipment as just sort of a low-hanging fruit harm reduction strategy. That's a good question.
In kind of a similar vein to Shree's question, you had mentioned kind of asking people like, what are you doing to stay safe or to reduce risk? And then mentioned like there may be some things that people will bring up that are potentially intended to reduce risk, but actually might not and may potentially increase risk. And I was just wondering if you had like heard anything from Jessica or maybe had like a brief list of sort of common things we may hear from people, where if we hear them, we should like have a little alarm bell go off and say like, maybe we should counsel this person, like maybe consider not doing that behavior. I mean, to me, like hearing I lick the needle before I inject myself, or I like put lemon juice on something that I then introduce into my body, like those ring alarm bells regardless. And it seems like common sense to advise people not to do that. But I don't know if there's like anything else that's maybe a little bit less common sense where if I hear it, I should be advising people against it.
Yeah, that's a good question. I don't know that I've encountered anything that feels sort of not particularly common sense. I think a lot of the other common ones are trying to avoid injecting into the groin if possible. You want to be further from your heart if okay. But I think oftentimes when people are injecting in the groin, it's because other veins are no longer a good access site. So I think that's like oftentimes people are like really sort of thoughtful and intentional about these decisions. So yeah, I don't have anything that comes to mind about something that would be sort of a red flag to think about, but wouldn't necessarily put you on alert otherwise. That's a good thought. Okay, so I'm going to move into the last section, thinking about ways that we can be advocates. And this is actually a quote about from And the Band Played On, which is about the HIV/AIDS epidemic, saying that what society judged was not the severity of the disease, but the social acceptability of the individuals affected with it. And I feel like that kind of really, for any sort of epidemic that is something that's stigmatized and doesn't necessarily receive sort of the amount of attention or funding for the number of people who are harmed or die because of it. I think that kind of really encapsulates what's happening with meth and why it can be so hard and distressing as providers to take care of patients in that setting. So one of the biggest ways I think that we can be advocates is thinking about treatment. So SAM is really interested in cutting back on their meth. They know that they would love to stop using or at least really cut back on it. So quick question, which of these interventions are supported by RCT data to effectively reduce meth use? And we'll put up a poll. and you can choose all that apply. And then, Lauren, I don't actually know, do I end the poll? Do you end the poll?
I'll do it, and then it'll like pop up on everyone's screen.
Sounds good. Thanks.
People are still thinking, so we can give them another.
Okay.
Mary from the chat, there's a request from the handout that Espert provided. Do you have that in like a PDF form to drop in for us or something like that?
Yeah, absolutely. Yeah, I will do that.
Yeah, you can do it later, but yeah. All right, last votes in the next couple seconds.
Cool. Okay, beautiful. So pretty big distribution, kind of some votes for everything, with CBT and DBT kind of leading the pack. Okay, so I would say the strongest data is for these three. So for contingency management, which we'll talk the most about, methylphenidate I think is kind of plus minus, and mirtazapine there's some weak data for. There actually is a little bit of data for CBT and DBT. Just when you're thinking about psychosocial interventions, contingency management is so much stronger. And again, we'll go through kind of exactly what that is. That's really kind of where the strength of the data lies there. And so bupropion, unfortunately, hasn't borne out. SSRIs have been tested and haven't borne out. Suboxone has been tested and hasn't borne out. There's a little bit of interest in Wellbutrin naltrexone, but there was like a New England Journal paper last year that showed like maybe some weak benefit in some patients, but nothing super, super convincing. Okay, so treatment obviously can look like two things. It can look like medications that we prescribe or like different psychosocial interventions, and oftentimes both together, like when we think about depression or things like that, work best. I would say that right now the data for meth is really in the psychosocial category, and it's maybe not so much that no medications have worked as much as like there just haven't been that many studies, and we'll talk a little bit more about that. But do you want to spend the bulk of the time talking about psychosocial treatments, because again, that's really where the data is. And so the biggest one is contingency management. This is kind of the most robust data source. And then some other ones that have been explored are tailored CBT, which again has maybe some modest benefit. And then community reinforcement, which is more about sort of thinking about how can you kick meth out of the environment. So I have just a really short video to show you that kind of encapsulates what contingency management is. Hopefully this will work. In just a couple of minutes.
So we're going to start today by having you do a UA.
Okay.
So if you don't mind, we'll just have you take this and stand up and just head out that way.
Okay, I can do that.
Great.
All right.
Great, Paul. Thank you so much. So we are going to click this here. How's your day been? Pretty good. Good, good. So now we're looking to see you are clean for cocaine, amphetamines, methamphetamines, THC, and heroin. So it means you've been in the study for 4 weeks. That means you get 5 drops. Sound good?
Yeah, sounds good.
Excellent. Okay. Shake our bucket. Okay, first draw. What do you got?
Small.
Good job.
All right.
Nice. Go back in there. What's this?
Small.
Small? Great. Good job. Go ahead. 2 small.
Can we get a different color?
What's this?
Large! Hey! Alrighty, that's the ones I like.
Good job. So that's 2 smalls and a large. So we'll stand up here and have you look at our cabinet.
Okay. Alright.
There we go. Sorry, got a closed door.
Oh, hey.
And grab yourself 2 smalls and a large fries.
Okay, small here? Okay. Oh, wow. What a decision. I don't need no mac and cheese, though. Oh, I'll take 2 tips. Oh, where's these? Oh, no. Yes, the lips.
Excellent.
I'll take lips. Okay.
And you can get another small too.
So one more small. Is that a whole cup full of goodies?
Oh, they're just one each.
Just one each, okay. Oh, well, oops. I'll take the gloves.
Great,
And the gloves this time of year, okay.
And a large?
And a large, is that this shelf?
Yep, that's that second shelf.
That's that one there, okay. What is this here? Oh, we'll take this one.
Fantastic.
Okay.
Okay. So contingency management, like that video showed, is basically a program where people are, if a UTOX is negative, then you sort of draw a number to see whether or not you're eligible to get prizes. And it seems like this is actually like a pretty effective treatment modality for methamphetamine use. We'll kind of go through the data quickly. I'm just being mindful of time. Would it be helpful to like talk in a little bit more detail about what contingency management sort of is and how it works, or does that feel like a sort of sufficient like introduction? Okay, I'll keep kind of moving on. Okay, so again, just to kind of like brief overview of what the landscape of research looks like. This is from Systematic Review. So there have been 27 trials looking at contingency management. 17 of those are actually RCTs, and then some of them are pre-post analyses. All of them included case management. There was some heterogeneity in terms of some also had CBT, some also had case management, although most of them did. And then very variable populations. So again, a little bit of a heterogeneous data set. But in 26 of 27 studies, contingency management reduced meth use. Reduced cravings, reduced sexual risk behaviors, and then increased treatment retention, mood, and affect. Reduced abstinence is that was it, I think. And then in terms of follow-up, I think the big takeaway is that it was limited. So just in terms of thinking about kind of the time scale that this happened on. So the longest duration of any program was only 4 months, and there was maybe some signal that a longer program was slightly more effective, but hard to say. And then the longest follow-up was only 12 months. And so it did show some durability at the 12-month mark. So even after the program ended, that meth use continued to be lower than it had been prior to the intervention, but no follow-up happened kind of beyond that 12-month period. And so unfortunately, there are a lot of limitations to contingency management. And that's why, even though the data looks really promising, the only place that it's ever been available in Seattle is at the VA. And that program is unfortunately currently on hold due to COVID, and it really hasn't been otherwise available. So I think one problem, although I don't think that this is the reason that it's not available, is that it does map onto existing inequalities. So the people who did best in these trials were HIV negative, Caucasian, more education. I think, again, not surprising, but I think it does sort of risk not necessarily being the most effective intervention for communities that might be hit the hardest. I think the bigger sort of functional question is, how do you fund these incentives? So sort of buying the prizes that people are then able to choose, which are really sort of the hallmark of the therapy. Medicaid unfortunately limits incentive funding to $75 a year, which probably sort of had a rationale at some point. But given most of these programs are funded by Medicaid, with the exception of the VA, it means that most of them don't have a way of allocating funding to actually pay for the incentives. There's also cultural resistance to this idea that motivation should come from within, or like recovery itself is the reward. So I think that there can be a lot of discomfort with the idea of sort of rewarding like something that people feel like people should already be doing. And I think that can sometimes be a little bit of a tough hill to overcome. And then finally, the durability really remains a question mark, primarily since we just haven't looked at it. And then I'm not going to talk too much about medication. I think the one that you'll probably hear talked about the most is mirtazapine, which now has 2 RCTs showing some kind of modest benefit. This was the most recent one from early last year. And you can see here graphed is the proportion of positive UTOXs. And so it does go down in the mirtazapine arm. My impression from talking to providers is that this has not really radically changed anyone's practice. that it feels like it's a pretty modest benefit and maybe worth it. I think oftentimes it's like, well, it's a low harm medicine. Maybe they have a little depression as well. Maybe it'll be helpful. But it's certainly not a panacea. And I think we think about it most maybe as an adjunct, but really not primary therapy based on the data that we have thus far, unlike something like methadone or Suboxone.
Mary, maybe just another thought or two to wrap up, for a minute or two more.
Yeah. Okay, so last I'm going to talk about community advocacy. And I think the big thing to know is that there's a bill in the Washington legislature right now on decriminalizing drug use and possession. So just one as like kind of an action item here. There's a way that you can find your representative and encourage them to support that bill. I think this would go sort of a long way in sort of addressing some of the like bigger picture sort of social issues around methamphetamine use. And then finally, there's a lot of interest in safe consumption sites in Seattle, which I would love to tell you more about, but maybe we can talk after if someone's interested. And then just take home points, you'll see a lot of patients experiencing meth. Rates continue to rise. It's disproportionately affecting communities of color. And then like I talked about, a 3-step framework for approaching meth. So thinking about reducing harm, connecting to resources, and then being an advocate. And then I put the checklist and SBOT pearls up here as things if people want to use those as takeaways. And then I'll also send out the SBOT PDF as in the chat right after this.
Awesome. Thank you so much. This was such a great talk with a lot of like very actionable things for us to apply to our patients. Really appreciate it. Interns, you are going to go ahead to intern mega report, and I can put the link in the chat for you there. And then everyone else, we can take a 5-minute break and then come back for our final session.